Hi, this is Deb, and this is the introduction to Foundations of Nursing 1. The first topic that we talk about are effects of and problems with immobility. Our ability to move is really essential to our sense of well-being. Many individuals define their health status by their ability to remain active and doing the things that they want to do for quality of life. So really being able to move is an essential part of our overall well-being. If you remember Healthy People 2020, you talked about this national initiative in intro, and there is an objective in Healthy People 2020 that pertains to exercise and activity. It's always kind of nice to look at the statistics. As you generally know, the population in the United States is aging very quickly because of all those baby boomers that are getting to the older adults. 47.8 million and 65 older in 2015. But look at the jump in just a year. It almost doubled in a year. And then 85 and older is the fastest growing portion of our population. People's life expectancy has risen. People are active longer, doing more things as they age. Almost 20 million estimated 85 and older in 2016, which has been a few years ago. And 10% of those 65 and older have Alzheimer's dementia, which is kind of a concerning stat. And there's just a recent article that I read that said they're guesstimating that incidence of Alzheimer's dementia will triple in the next 20 years. And that will have an impact on people's ability to stay active and independent. Stats from the U.S. government are generally several years behind. This was a recent article in November of 18, American Nurse Today, and these were the most current data that the U.S. government had published on aging. More than 10,000 people turn 65 every day. Most of those people have at least one chronic health condition. And a lot of the focus for this course is older adults and management of chronic health conditions. Most people don't just have one. If they have one, then they progressively develop other problems, which we're going to talk about throughout the semester. Life expectancy has increased. Women on average live to a little over 81, lower 80s. Men not quite as longer, upper 60s. For the first time ever, life expectancy in the U.S. dropped by a year this last year, and that is related to the opioid crisis and more people dying from drug overdoses. A lot of people that are over the age 65 are still working, and we're going to have a discussion about that in class. 46% of women older than 75, so almost half of women over the age of 75 live by themselves. And we're going to talk about the impact of that on that population. And they're estimating that people over the age of 65 will be almost 100 million by 2060. So if you look at what's going on just here in eastern Iowa, the amount of services for older adults has increased dramatically in the last 10 years. Residences, condos, living facilities, not necessarily just long-term care facilities, but assisted living and places where people can age in place. And this is just another way to look at the data, the number of people 65 and older, and that expectation of how many people that's going to impact over the next 20 to 30 years. So let's talk first about normal movement and what that means. All of these, the physiology of normal movement, all is dependent on brain function, joints, muscles, balance, coordination, all those different kinds of things. Proper alignment, which prevents strain on joints, muscles, tendons, everything. Your body just works better when everything's in alignment. Looking at someone's overall alignment and posture can give you an idea about their overall general health, their mood, their self-esteem, maybe even personality. You look at their line of gravity, the center of gravity, and the things that are supporting that posture and proper alignment. Joint mobility, bones articulate at the joints, most skeletal muscles attached to the two bones at the joint. Range of motion, what normal range of motion is depends on which joints. All of our joints move a little bit differently. Shoulder joint, very complicated, goes round and round, up and down, back and forth. But the knee joint only moves back and forth. It's not supposed to go round and round, and it's not supposed to go backwards and forwards. So range of motion, definition of range of motion, is maximum movement that joint is capable of. So range of motion is the maximum movement that joint is capable of. And some of the things that affect range of motion would be genetics, developmental patterns, whether they have any disease process that affects the joints, and the amount of physical activity that someone gets can affect their joints. Balance can be influenced by inner ear, vision, stretch receptors, proprioception, which is awareness of your body position and movement, and then changes in equilibrium. And then coordination. Cerebral cortex in the brain initiates voluntary motor activity. Cerebellum coordinates the movement. And the basal ganglia helps maintain posture. Things that affect movement and alignment, growth and development, so someone's age. So if you think about normal growth and development, newborns' ability to move and be aligned is different than, say, a 1 or 2 year old or a school-age child or an adolescence. We'll talk a little more about these different age groups in class. Just know that as you grow and develop into those phases, your body changes, the composition changes, your ability to do things, coordination changes, and so on. 20 to 40-year-olds generally don't have many things going on that impact mobility, maybe injuries of some kind. Women, if they become pregnant, that can affect their joints in the pelvic area, and weight, and changes in the curvature of their spine. Could cause center of gravity issues and balance issues, but generally once they deliver, then those issues are resolved. And then as we age, things that change are bone density, less flexibility joints, reaction times are slower. Those people that exercise or have regular activity reduces that effect of aging on the joints and muscles. And then we're going to talk about impact of illness on activity. There's lots of examples of that. Anything that affects the central nervous system or the brain can cause issues with being able to move and be aligned. The Unit 3 is on neurological deficits, and we'll talk about a lot of those things that affect people's mobility. Other things that can affect movement and alignment, nutrition. Nutrition is a very important topic as we talk about people's ability to manage their chronic health conditions. If they have more nutrition than they need, they could have issues with obesity, stress on joints, could have balance issues, posture issues. Those things could affect their ability to move and be aligned. Less than body requirement, so they don't have enough nutrition, and this is a common issue for elderly adults that may have issues with malnutrition, changes to their GI tract and so on, can cause issues with appetite and not being able to eat. They could have osteoporosis, issues with bone density, muscle weakness. Muscles need nutrition in order to stay strong and not lose muscle mass, and fatigue could also be a result of not having enough nutrition. Some of the things that we don't necessarily think about when we think about things that affect movement and alignment would be, what is your personal attitude about moving and activity? What's the value to you? And some of this may be something that you've grown up with, a family influence. Physical appearance may be a detriment, may influence your participation in exercise. What's your personal motivation? Your occupation may impact. Now, most of us that are nurses don't really have an issue getting enough activity into our daily schedule. One of the clinic instructors shared with me that she wore a pedometer tracker this last semester for clinic, and she would log in 6 to 8 miles a day just at clinic. Other occupations that are sitting at a desk all day, that could have a huge impact on their ability to get enough activity during the day. External factors, the external temperature, humidity level, availability of safe places to walk, excessive use of computers, TV, and video games. The more that the hours go up, or the minutes and hours go up of using electronics, decreases your ability to your movement and getting enough activity. Prescribed limitations would be something, say, that someone would be prescribed for whatever reason a period of bed rest or inactivity. Benefits of that would be promotes healing, rest, reduces edema, reduces metabolic demands, decrease of pain, allows some tissue repair. Associated risks of bed rest: the longer that someone's immobile, the longer it takes to recover from that. Loss of muscle mass, risk for DVT. We're going to talk about different kinds of risks, what happens when people are immobile. I think particularly for our older adults, the risk for falling increases as one ages. 30% of people over the age of 65 fall annually. 30%. So 3 out of 10. 50% of people over the age of 80 fall annually. So that number jumps up. Over half of them fall every year. Almost half of the falls are caused by a balance. They're incorrect weight shifting. They lose their balance. Maybe they've got gait disturbance related to pain, joint, muscle atrophy or something. Risk factors include chronic illnesses that may impair their ability to focus and concentrate and pay attention. It may affect their coordination. It may affect their muscle strength. Fall injuries are the leading cause of death by injury in people over the age of 60. And we'll talk about the impact of someone falling and what it's kind of like a big stack of dominoes that once they fall, all these other things happen because they're suddenly have an injury of some kind. Average cost of a hospitalization for people that fall average is $35,000. And that may not include surgery to repair, like a fracture or something like that, or extended stays in a skilled facility or rehab facility to recover. 1 in 4 older adults fall every year. Less than half tell their provider. And I think that is significant. We have to encourage our patients to share that information with us, and we have to create a safe environment for them to share that information with us. They think if I tell someone that I fell, they're going to put me away in a home someplace and I'll never go home. Polypharmacy is a huge issue for older adults. So they have to be able to tell their provider that I did fall. They need a review of their medications. They need one person to review all the medications. A lot of older adults end up with multiple providers, and so nobody ever looks at the big picture. Does that person need strength and balancing exercise? Do they need to go to physical therapy and get some exercises to do so it doesn't happen again? Is their vision okay? Has anybody done a home safety assessment? Do they have grab bars, railings on the steps? Do they need additional lighting? So all those things need to be evaluated because older adults are at higher risk for falling. So our primary focus on this chronic disease management or medical management of these chronic health conditions, really we want to focus on prevention of it getting worse or prevent those complications that people end up being in the hospital or something bad, a bad outcome happens. We're going to watch this video in class. I'd encourage you to look at it because it comes at the healthcare system. Current management focus is on we're rescuing people. After something bad happens, then we rescue them. What if we flip the focus to let's look ahead and let's see if we could prevent something bad from happening, which would save a lot of additional expense to the healthcare system and keep people functioning at a higher level better. All right, let's talk about types of exercise. This should be a review of discussion you've had in A&P. Isotonic, active movement, muscle shortening. So the muscle shortening and there's active movement. This is range of motion. Range of motion is active movement with muscle shortening. This could include activities of daily living. Swimming would be isotonic. It's active movement with muscle shortening. The benefits: it increases muscle mass, tone, strength, helps with joint mobility, improves cardiac and respiratory function, increases circulation, and it increases bone building. Isometric, muscle contraction without moving the joint. All right, so the muscle length doesn't change. So it's like exerting pressure against a solid object. So you can strengthen your abdominals, your quads, your gluteals. You tighten them and relax them. So it would be like doing quads, where you're sitting in your chair and you tighten up your quads, your thigh muscle, and then you relax it. So the joint's not moving, the muscles aren't moving, but you're contracting it and relaxing. Isokinetic is muscle contractions with resistance. So this would be like lifting weights or the stretchy bands that physical therapy uses. So the person is working against resistance. And then aerobic, sustained muscle movements, large muscles that increase blood flow, heart rate, metabolic demand. So walking, jogging, this could be high impact or low impact. Effects of exercise. We're talking about what are the positive effects when someone gets regular activity. And I think the current recommendation now is 160 minutes every week, which breaks down to about 30 minutes a day. And there's some research that suggests that you wouldn't even have to do that 30 minutes to an hour consecutively. You could do 15 minutes, 15 minutes, 15 minutes, or 30, 30. You could break it up throughout the day. What the point is they just want people up and doing something. All right, so we're going to do an activity in class on the effects of exercise. This should be a review from normal A&P. So this slide and the next slide, we will do this in class. And again, those positive effects of getting regular activity. All right, review the nursing process. Here we are, first week of the nursing program, and we're already in nursing process. Now you've done this in intro, and the intro instructors and the Foundations 1 instructors work very hard to make sure that we are consistent with the information that we're giving you. So make sure you review the nursing process from intro, because now we're going to take it and apply it in specific informations. If you remember, the nursing diagnosis is the patient's response to something that's going on. Okay, it's the problem. It is not a medical diagnosis. All right, and we're going to do some activities in class to review this process. Etiology is what is the underlying thing that's causing the problem. This is not a medical diagnosis either. All right. So this is the underlying problem. Let's really drill down and get to what the problem is. All right. And then the defining characteristics are your assessment information, subjective and objective, which then would support why you picked this diagnosis and this etiology. So it's not everything under the sun that's on their assessment. You're going to pick out those things that are key to support why I picked that problem. Prioritization is something that we work on a lot. We base it off of Maslow's. There's other things that you've talked about in intro which are could apply also. If you think about airway, breathing, if we're not breathing, that could be a huge issue. If we're don't have adequate circulation, something's wrong with our heart or circulation of any kind, that could be an issue. If there's a safety issue, that could be a problem as well. So we practice prioritization in the classroom and on care plans, and you'll do this also in clinic. It's practice because it's not always the same every single time. You have to evaluate the whole picture. You have to determine then what is the most primary thing that I need to address. And this is just another tool that kind of breaks it up and makes it a little more descriptive. You're going to look at your assessment, subjective, objective. Objective is really data, what you're collecting. Subjective is what the patient tells you or someone else tells you. And you split that up between those two. You're looking at assessment generally for your patient. Using your assessment information, determine what the problem is, your nursing diagnosis, and the goal. So students struggle with goal setting. All right, if you have a problem, your goal should be, how will I know that that problem is better or gone? All right, so if I have a person with activity intolerance, which means they get super tired when they get up and do anything, how do I know that that problem is better? How do I know that they're tolerating activity better? It has to be specific, measurable, attainable, realistic, time limited, those SMART goals. So a way to determine that activity intolerance is better would be their heart rate is within normal limits after activity. So a specific goal would be the patient will have a heart rate of 80 after walking 50 feet in the hall by the end of the week or in 7 days. Specific, I know what my target is to have their heart rate 80 or below. Measurable, I can measure that. Attainable, realistic, hopefully so, and then a time limit in 7 days. That would be a specific goal to tell me that their activity intolerance is better. Using the goal then, determine the actions by the nurse. All right? So the patient goal is the patient will, the nursing interventions are the nurse will. So if my goal is that their heart rate is going to be 80 after activity in 7 days, what am I going to do that? We're going to slowly increase their activity. If they've been on bed rest, we're going to let them sit in the chair for 20 minutes twice a day. That's probably enough activity if they've been on bed rest for a while. We're going to have them walk 20 feet 3 times a day. We're going to have them get up from the bathroom and from the bed and walk to their bathroom. We're going to have them walk X number of feet in a certain time frame. Those will be all interventions that would help us reach that goal. This is just what the nursing care plan grid looks like. This should be similar to what you've used in intro. This will be the grid that you work on care plans in class, for classroom assignments, and in clinic. All right, effects of immobility. So now we're going to talk about what kind of things happen when someone is immobile. So this also is a classroom activity, and again, it recalls a lot of information that you learned in normal A&P. What happens to the body when it's not moving, when it's inactive, when it's immobile, we're off our feet for a period of time. So the cardiac system, make sure you look at this. What happens to their fluid? What happens to the skeletal muscles? What happens to their stroke volume? What is cardiac deconditioning? What is postural hypotension? What happens to their blood pressure? What happens to their heart rate? So understand, we know what happens positively with exercise. What happens when they don't exercise? What happens when someone's off their feet? What happens to their breathing? You have to know what tidal volume is, residual volume, forced vital capacity. What happens to the structure of the lungs? What happens to the diaphragm? What happens to the alveoli? What is your patient at risk for if they're not mobile? What can happen to their lungs? Hematological system, all right, so blood vessels, blood components. What is viscosity and what happens to viscosity? This kind of relates back to the cardiac system. What is erythropoiesis? You need to look that up. How is that impacted by immobility? What stimulates erythropoiesis? How is oxygen transport affected? Virchow's triad relates to risk for deep vein thrombosis. What causes stasis? Why do they become hypercoagulate? And what happens to the blood vessels? Why are they damaged? What happens to the musculoskeletal system? And we kind of talked about that with the effects of exercise. What happens to their muscles when they're not being used? What happens to the connective tissue if their joints and muscles aren't being used? What's a contracture? Why does it develop? What's the underlying cause? What happens to the bone and the bone structure when someone's immobile? Endocrine system. Now, this is something typically students struggled with in A&P. This may be worthy of going back to look at that section on the endocrine system. So we're talking about stress hormone. We're talking about cortisol. What happens to metabolism when someone's not moving? What happens to glucose levels and why? What happens to the RAS system? What happens to their electrolytes and their minerals because they're immobile? What happens to renin, angiotensin, aldosterone when they're immobile? Those would all relate to the endocrine system. What happens to their skin? The second half of Unit 1, we're talking about issues with skin, so this is kind of an introduction. What happens to skin when someone's immobile and they're not moving? Why do they develop redness? What causes ischemia? How does nutritional status affect one's skin? What happens to someone's immune system when they're immobile? They develop inflammation, but why do they develop inflammation? What are cytokines? What happens to their white blood cell and their immune response? What happens to the GI system when someone is immobile? Why do they have a decrease in appetite? What is peristalsis? What happens to it? What is motility and what happens to that? And what's the overall effect of the GI system on everything else? What happens to the renal system? What happens to the kidneys and the ureters and the bladder? Why would they have an increased risk for retention? And why would they be at risk for developing calculi, which are renal stones? What's the effect of immobility on someone's nervous system, so their brain and the nervous system, and how does that affect their psychological well-being? Some things to focus on for someone's focused mobility assessment, things to consider. would be their history. What was their problem? When did it start? How often has it been going on? How has it impacted your ADLs? How are you coping with this? What makes it better or worse? What type of activities make you tired? Do you get dizzy, short of breath with activity? Are you able to go up and down stairs? A safety assessment for railings and grab bars and assistive devices. What's their body alignment? What's their gait like? What's their joint movement like? Has something happened that they have now issues with limitations? Can they move as well as they did? Are they as mentally alert as they were? Balance coordination. Muscle mass. Older adults, just because this happens to every older adult, whether they're active or whether they're not, they lose muscle mass. Part of the aging process is you have decreased muscle mass. So if they're older adults and they have decreased muscle mass and now they're suddenly immobile, now we have a huge issue with muscle mass. Can they do those things? Can we help them do things that will increase that muscle mass in those key muscles to keep them mobile? And then do they tolerate activity? And we talked a little bit about that. You have to look at criteria for stopping activity as well. Where's the point where you draw the line and say, okay, we've overdone it? If someone's dizzy and lightheaded, if someone's O2 saturation drops significantly, changes in mental status, they get dizzy, their blood pressure drops, heart rate or respiratory rate go up significantly. So those will all be things, criteria to stop activity. So we talked a little bit about goals. These are pretty broad and general goals. The goals that are listed in ACLI, the Nursing Diagnosis Handbook, are vague. So you have to take them and you have to make them specific for your patient that you're taking care of. And then we're going to do a classroom activity for identifying goals. Okay, nursing interventions. Safety for nurses. Part of coming into the nursing program is getting your CNA. You've had some clinical with that. You've talked about some of those basic safety things in intro lab. The American Nurses Association had a national initiative 2 years ago on safe patient handling. We have to protect ourselves. Nurses are at severely high risk for injury, for workplace injury, and that chronic long-term joint and mechanical movement issues. Because of the patients that we move, the patients we're responsible for, we turn, lift, and move patients that are increasingly larger all the time, and we are at risk for injury. When I first got out of nursing school, this really was not identified. You knew that you needed good body mechanics, but we still moved patients by ourselves. We did the best we could with short staffing, and most older adults that have been nurses may have back issues, shoulder issues, knee issues, foot issues related to that chronic overuse of and stress on those joints. So we want to protect ourselves. We want to do adequate positioning, which we're going to talk about in the effects of immobility with the skin part. Transferring, mechanical aids, lifts, draw sheets, and those kinds of things. And then manage what happens when you become fatigued. You're higher risk for injury if you're tired. So there's 2 articles posted on Talon. One is Basic Nursing Care to Prevent Non-Ventilator Hospital-Acquired Pneumonia. And the second is Frequency and Duration of Nursing Care Related to Older Patient Mobility. So just when you're looking at a research article, look at the summary first that kind of drills down to this is the main key points from the article, and then just skim through the article. But what I want you to start thinking about is how does evidence-based practice research apply to me as a first semester student or as a nurse. And so we're going to talk about these two articles and how they relate to preventing pneumonia for people that are high risk, and also preventing issues with immobility, particularly for older adults, and looking at patient or nurses' attitudes and their thinking about how important mobility is. Nursing interventions, which again, we're going to talk about nursing interventions related to these body systems when we talk about the effects of immobility. We'll talk about the effects of immobility, and then we're going to talk about what would you as a nurse do. So I think the biggest takeaway for nursing interventions is once you understand the risk of someone when they're immobile, all those risks for their total body function, prevention is the key. What are we going to do to prevent them from developing all these terrible things that happen when someone's immobile? And we'll talk about these related to the body systems, the cardiac system, the respiratory system, body positioning, and so on. And again, nursing interventions related to preventing issues with musculoskeletal, integumentary, metabolic, endocrine, elimination, GI, GO, and psychosocial. We're going to have a brief introduction to anticoagulants, knowing that in a few weeks you're going to have a more in-depth discussion about anticoagulants in the pharmacology course, and then again we'll revisit the anticoagulants in the cardiovascular unit in the second half of the semester. So basic introduction about pharmacological interventions for people that are at risk for DVT, particularly those people that are mobile. Now, I would encourage you to pull out your med cards, the stack that you bought at the bookstore, and I would encourage you to start filling those out as we discuss medications in class and in pharmacology, because you have to have medication cards for your patients' medications in clinic the second half, and if you don't do any of these med cards ahead of time, you're going to get absolutely overwhelmed by the number of medications that people are on a med card for each one. So I'd encourage you to start filling those out with the information about each of these medications. Heparin inhibits fibrin formation. It's generally given IV. It can be given subcutaneously. The advantage of heparin is it's a rapid onset. It starts working within minutes. And it rapidly clears out of someone's system. So once you stop it, it clears out of their system right away. A lab to check for heparin effectiveness would be a partial thromboplastin time, PTT. This can be given IV. We'll talk a little bit about this. Can be injected directly into coronary arteries in order to prevent clot formation while they're working and they're doing interventions such as stents or bypass grafting. As a sub-Q injection, it's injected 2 inches around the umbilicus. Do not massage the area once you give it. It does sting a little bit. It's a little painful. They may have bruising at that area because it's an anticoagulant, but you don't massage the area. So 2 inches around the umbilicus. Enoxaparin also inhibits fibrin formation. This is usually given subcutaneously. People may go home on this. The heparin is generally in a very closely managed acute care situation. Generally, people do not go home on heparin. Enoxaparin, Lovenox, people do go home on that temporarily. Subcutaneously, you inject that around the outside abdominal border. So it's kind of like a big box around their abdominal space on their abdomen. Partial thromboplastin time would also be the blood test to check for this. people will go home with this after, say, a joint replacement or someone who's had a DVT that's at high risk for redeveloping. So they may go home for this for on like 4 to 6 weeks, generally not long term. The other thing that you need to know is if there's an issue with bleeding, can we give something that reverses that anticoagulant? Heparin, the reversal agent, is protamine sulfate. So if we determine that their PTT is significantly elevated, it's too high, they're bleeding out of different places around their body, they might give them protamine sulfate to reverse that, and then that would stop the bleeding. The enoxaparin really doesn't have a reversal agent. So that becomes an issue if they've gotten too much enoxaparin. Bleeding precautions is a significant factor for people that are on anticoagulants. And we're going to talk about those here in just a minute. So make sure you're filling out the med cards for these. All right, Coumadin, warfarin, Pradaxa, and Xarelto. Now, there are 2 more new agents. These are really the ones we kind of drilled down to that you're probably going to see the most common. Warfarin has been around for decades and decades and decades. It's really old, it works pretty well, and it's very inexpensive. So but it's very tightly managed. The issue with warfarin is that there's a lot of nutritional restrictions. You have to frequently have blood work done to make sure that the level is within range. Any sort of food that has vitamin K in it will decrease the effectiveness of the warfarin. INR, International Normalized Ratio, is the test that they do to determine whether warfarin's in an effective range or not. Reversal agent would be vitamin K. As you're starting to complete med card, you're going to find that there are many, many, many medications that interact with, either make warfarin over effective or blocks the effective warfarin. So it interacts with a ton of medications, interacts with a lot of nutrition issues, so that's more delicate to manage this. Pradaxa is used to decrease the risk of stroke and systemic embolism with atrial fib. So atrial fibrillation, if you recall from A&P, the atria do not contract and empty. The blood pools there, which increases their risk for developing little microscopic blood clots in their atria. And then if it happens to contract, then it shoots those little blood clots out all over the place. Unfortunately, there's no blood test to tell whether this is effective. They don't think there's food and drug interactions. There have been some class action lawsuits for Pradaxa because there's no blood test, so they can't really tailor a dose individualized. They just give everybody a dose and say, well, this should work for most everybody. Xarelto is used for prevention of DVT, particularly after knee or joint replacements. They have a greater than 95% risk of developing a DVT after a joint replacement. There's also no blood test to monitor the effectiveness, so everybody just gets started on it. You've probably seen the ads on TV, Pradaxa and Xarelto. I don't have to go get blood work done. It's very easy. I just take a pill and everything's great. Again, some class action lawsuits for Xarelto related to too much of the blood in their system. They have a bleeding or a stroke event, or they have a clot event of some kind. Now, there is a new reversal agent that was developed several years ago, and Dexa was developed in order for, if someone did have bleeding with this medication, that they would be able to reverse it. So bleeding precautions, the main thing that I want you to know about medications for Foundations 1 is most patients are going to take these medications outside of our direct supervision. We may hand them medication occasionally while they're within our brief microscopic time in the healthcare system. Most of these people are going to take these things at home. What do they need to know if they're going to take this at home. What do they need to know about when to contact their provider? Is there anything, a particular complication for that medication, side effect, adverse effect that I'm really concerned about that your patient needs to know about? Bleeding precautions would be one of those. Those things that the patient should be using an electric razor. They shouldn't be taking any aspirin, which causes platelets to be a little less sticky, which increases their risk for bleeding. Small gauge needles. Make sure they're not doing any sort of contact sports. Caution with, if they're a risk for falls, then make sure that we've done those things to prevent them from falling. Look for, how would your patient know that they were bleeding? They may not have bright red bleeding, but they might have a change in their urine color. They might have a nosebleed. They might have bleeding in their gums. They might have suddenly develop bruising all over. So all those things would tell your patient that they need to contact a provider. Hot and cold therapy. Those are some of the things that we use to treat injuries or muscle limitation, joint limitations. There are some pages in Potter and Perry. These pages are incorrect. The correct pages are 1216 to 1220. Potter and Perry is the Fundamentals of Nursing textbook. If you haven't purchased your textbooks yet, I did post a PDF copy of those pages on Talon, so you can read those pages. There are 2 worksheets to fill out, one for hot therapy, one for cold therapy. So what are the physiological effects of application of hot or cold? What's the rationale for using it? Why do we do that? What are the nursing implications? All right, so what's important for me to know as the nurse? If I'm going to put some sort of cold source on someone's skin, what do I need to do? What would be my priority thing to do? If you're going to give directions to your patient to do this at home, what do they need to know? What kind of patient education do they need to know before they do this? Understand that people don't know the important things. They say, oh yeah, I've got it. I don't need to know information. I know how to do this, but then we never clarify to ask them whether they actually do need to know how to do that. So at the end, we do the nursing process, we've done our assessment, we've determined the problem, we've determined how will we know the problem is better, we've determined what I'm going, as a nurse, going to do to address the goal, to reach the goal. Then at the end piece, you got to evaluate, did it work? I had this goal, these are the things that I did I meet the goal? Was the goal met? Was it not? If it wasn't met, we need to evaluate the goal. Do we need to reset it, change it, revise it? If the goal was achieved, okay, we can move on now to the next problem because it's not a problem anymore, we've reached our goal. And that concludes the immobility portion of Unit 1.